Welcome to Healthcare Huddle's Huddle Chats. This is the first one. These are 30-minute chats with industry experts to discuss the latest in healthcare at the intersection of business and patient care. I'm Dashevsky. I'm founder of Healthcare Huddle, a weekly healthcare newsletter that breaks down key healthcare trends for physicians, providers, and medical students, since they seldom have the time to stay up to date themselves. I'm also an incoming internal medicine resident in New York City with plans to go into gastroenterology. I won't get ahead of myself though, because that's years down the line. In today's Huddle Chats, we'll be talking about private equity's role in healthcare, the good, the bad, and the ugly. Before introducing my esteemed guests, I just want to go over some ground rules. So first, all huddlers will be muted. We have a whole SWAT team of work week folks who are muting everyone as they come in. This chat will be recorded for those who couldn't make it. I encourage emoji reactions, especially if you like something or don't like something. The workweek team will include a Slido link where you can ask questions that you have on private equity. Don't use the chat, use the link because the chat will get very crowded. We'll answer all questions at the end. We'll try to answer all of them, but I don't think we'll be able to. And then lastly, stay curious. And I'm so happy to have Dr. Adam Brown today as a guest. He's an emergency medicine physician, teaches business at the UNC Chapel Hill Business School. He has an MBA. He also has healthcare executive experience. He was president of EM at Envision Healthcare. He's an entrepreneur and recently started his own healthcare consulting firm called ABIG Health. He has his own weekly newsletter, which I suggest you check out. I wish to emulate Adam's career, as I think is a good combination of patient care and business and management, which allows him to have this very unique perspective on the most pressing issues in healthcare, especially the more nuanced ones like private equity. So Adam, thank you for joining.
Hey, thanks for having me. I'm excited to be here today. And, I just have to say, Jared, I love reading Healthcare Huddle. I love kind of, you and I text back and forth when a big issue comes up. Love the discussion. And I think it's so important. It's really easy as we talk about these big issues in healthcare, get very black and white on things, but oftentimes the answers are a little more nuanced and they're a little deeper. And hopefully today we can get to some of that around private equity.
For sure. So let's get started. I'm going to assume that I have no knowledge on private equity. So my first question to you is, what is the role of private equity in healthcare?
Yeah, I think it's a great question because you really have to look at it from not only where does private equity sit in healthcare, but how does the role of profitability sit in the US healthcare system, and what are some of the other players? And I think kind of giving a bit of a background first of the players within the healthcare system in big buckets makes it a little bit more easy to contextualize the role of private equity. So we have to remember, in the US healthcare system, it is a for-profit system. It's essentially based on fee-for-service, meaning the more things you do, the more revenue you get, the more profit you make.
I think on private equity in healthcare.
One of the things that I think is really important is also to recognize that when we look at private equity in general, it is one of the answers on how do we make more money and profitability within the healthcare system. But there's other ways to invest in healthcare. There's government ways, there's stock market ways, there's then of course private equity ways, there's venture capital ways to invest money into healthcare and to help grow the system and be innovative. But private equity is just a piece. I mean, there are 5 essential components when we think about the ecosystem of healthcare, and that's the providers, so the hospital and the physicians and nurses that are providing the care. There are the producers, so the pharma device manufacturers that are producing the technology pieces. There are the patients, of course, that sit in the middle of that orbit. There, of course, are the government regulatory pieces. And then there's the payers in the healthcare system, like who's actually paying for things. And so when you look at the role of private equity, where does it sit within that system? You have to think about that it is clearly there to make a profit, but it's also there to help with innovation and be the answer to larger conglomerations and larger mergers and acquisitions that are taking place. And so to just say, is private equity good in healthcare, really requires a perspective to understand, to whom are you speaking? Whose perspective are you talking about? And then where does it sit? So then, to get to your question, what is the role of private equity and what's been happening with private equity in healthcare? We saw in 2021, in the middle of the pandemic, the biggest year that private equity has ever had in healthcare investment and buying up practices or buying up healthcare entities. And that continued into 2022, but down and towards the end of 2022, the last 2 quarters, that started to trail off. And part of the reason for that is inflation, increased interest rates, especially in the healthcare staffing space, labor shortages and issues. So those started to play in, and so that slowed some of the deals. So what's the role of private equity? It has a big role in healthcare, period. And part of the reason why it is there is I shouldn't say it has to, but it is there to help with investment and to help create capital and efficiencies within the healthcare system. Is it all good? Not necessarily. We'll get into that. Is it all bad? Not necessarily, and we'll get into that.
Great. That's a great answer. And I appreciate you just coming right off the bat and just saying, like, it is for profit. This is a for-profit healthcare system. And I think once you recognize that, then the way this system functions starts to make more sense. And so you touched on some industry trends in private equity. So I just want to share a graph or some data from PitchBook, which was analyzing healthcare PE deal activity over the past decade. And this includes like behavioral health services, primary care, specialty clinics, emergency rooms, you name it. So you do see an increase of like 200% between 2012 and 2021, with a little slowdown in 2022. But private equity has made it known that they're in healthcare and they're here to stay. And so my next question, when I was doing research on yesterday's Healthcare Huddle article, I came across some terms like platform and add-on, leveraged buyout. Could you speak on those 2 terms and describe what they mean?
Sure, but I'm going to simplify it just a little bit. Okay, so when we go to buy a house, right, and let's say that you're in the business of buying your own house, or maybe even you're flipping a house, there's a process that takes place. You have some money to start up, you go and buy a house, but you buy it on debt, and you buy it with a certain percentage of debt. So you hear things like 10% down, 20% down, 25% down. So when you do that, that essentially is you're buying a house with a small piece of capital, a small piece of dollars, and then you buy it with the hopes of making some improvements over time. And then as you make improvements over time, and as the market continues to move forward, and with inflation costs and with just general costs of or just improvements in general, and like the real estate market, your hope is to eventually sell that. And if you're in the business of flipping, you do it in a more accelerated time frame. It's not all that dissimilar than what happens in a lot of things that happen in business, where you have a certain amount of money to invest in, that's actual money that you have, and then you lean on other debtors to give you other amounts of money to then buy a product or buy a house or buy a car. So it's not that dissimilar. And I'm making it probably a little too simplistic, but I want to make sure that for folks, they understand that's essentially what happens. So when a private equity firm comes in and they say, hey, we want to buy physician practices, or we want to buy a group of practices, oftentimes what they'll do is they'll have some, of course, money to buy it, but they will use other sources of income through debt to purchase the entirety of the practice. And then what their hope is throughout the life cycle of that deal is to make operational improvements, to make capital investments. Those are these add-ons that they hope to increase the scale of the practice, because perhaps the practice was small and couldn't necessarily negotiate with the payers. Remember at the beginning, I was saying the payers are a part of this ecosystem. The payers are determining how much reimbursement goes back to the physician teams, the hospital teams. And the bigger they get, the negotiating power is smaller, of course, of the physician practices. And so what happens when you kind of scale the physician practices, then you start to have more of an answer to the payer side. So these things happen, you improve the efficiency, and your hope is then at the end of the day, then to sell it for profitability. And that's kind of how the process works. But it's not all that dissimilar to what we do even with purchasing a house.
I like that example. I wish you said that to me before I wrote the article yesterday. Would have helped me understand a bunch of things. All right, great. I think that's a good segue into the good, the bad, and ugly of private equity in healthcare. So let's first talk about the good, and I want to make some context. So let's say we're 15 years down the line. I finished my training. I am a GI doctor. My parents are so happy. And I joined this gastroenterology physician group that's approached by private equity. So what would be the good of going through with an acquisition deal?
So I was talking about this a little bit in the house example.
Mhm.
A lot of times private equity firms are very good at taking a very fragmented market and pulling together those pieces of the puzzle and then making it more efficient.
Right.
And so what you oftentimes will see is that when you have a company, let's say that, or let's say a physician practice, your GI practice, as you mentioned, maybe a standalone practice, there may be some inefficiencies there. There may be inefficiencies in your workforce. There may be inefficiencies in the revenue cycle. You may not have the greatest payer negotiations. So you may be getting one thing for the services you provide, but a larger firm or a larger group is getting another thing and a higher amount of dollars for it. And so when a private equity firm comes in, the value proposition for the buy is oftentimes better management and expertise. And that may be better business management, operations management, and expertise in that space. They may have better insurance rates, or when you pull the people together or other practices together, the rates and reimbursement rates may be better. There may be benefit to capital. The engine for innovation is the potential for profits. And so you have to have capital to innovate. So let's say you're a smaller physician group and you want to integrate with maybe even a payer, or maybe you want to integrate with hospitals down the line, but you need that IT infrastructure. There's a lot of dollars associated with that. You may not have the capital there to be able to do that. So things like new clients, capital investments, other infrastructures, back office supports, and even maintenance of your current salary may be required from a private equity firm. I know in my prior experience that oftentimes when groups would come to us, they were worried about not just being profitable, but being able to say, can we sustain providing the same level of the service, providing the same salary to our clinicians if we did not make some significant changes? And so, those may be some of the good reasons that PE would come in. And the last thing, Jared, on this is a lot of times we are starting to see a move. Medicare is doing this. Medicare Advantage is doing this, where you need a lot of data and a lot of infrastructure to track quality. And if you are a small player in the game, you may not be able to do that without investment. And so those are some of the good things that private equity can do.
Yep, for sure. I like those answers. And another question along the lines of like trends, like what are the patterns of like who is selling their practice to PE firms? Is it like the physician who's about to retire? Is it the group that needs financial support, like you just said? Or is it groups that just want to exit, like they've built their practice for years and now they're done?
I would say that answer would be, it depends. And I think you have to take a bigger look and say, what are some of the between micro and macro trends that are happening? We are seeing a growth, of course, in PE, but you're seeing a shift in the type of practices that are being acquired to PE by PE. And so, whereas, we hear a lot in the news about emergency medicine, or we hear a lot about physician-backed private equity groups that are the large hospital-based groups. Really, there's not been a lot of deal movement there, where there's been much more deal movement in dental care, eye care, podiatry, physical therapy. Those are where a lot of the deals took place. And then followed by non-physician practices like med tech, health IT, and then support services that surround the business and the practice entities, like revenue cycle management. Those are where a lot of the deals are flowing. So to answer the question on, what are some of the rationales, I think individually, when I've spoken to physicians that are considering to sell to private equity firms, the decisions are very different. Some may be a reimbursement problem. Some may be, well, they know they need to expand and scale, but they don't have the IT infrastructure. They don't have the capital there that's available, but they know they have to do it. And so what are some of the options? Some maybe they need back office management. So some of the reasons that I talked about in the good, they may be realizing the need to sell out.
Cool. That's very insightful.
But
All
hey,
right.
Derek, real quick before you go, those are some of the same value props and reasons why people sell to like a hospital system.
Right. No,
Or
for sure.
yeah, or become a part of a payvider kind of conglomerate. So it's not just a private equity. The problems may be the same, but the value props may be similar, just the decision may be slightly different depending on the outcome.
Right. It's like United Healthcare and Optum, they're doing the same thing.
Exactly.
Health systems. All right, cool. So moving on to the bad. So let's say my GI practice goes through with the deal, but I'm not happy. What's the bad of the private equity side?
Very simply, you can lose your autonomy as a physician who's running your practice.
Right.
And sometimes that's a blessing and a curse, but that can be a problem. So there also may be a shift in the incentive focus. So usually when you have a physician that's there, even those that are running practices, they are kind of thinking through two minds. One is, of course, like on the patient outcomes, we're trained that way. We're trained to look at the quality. We're trained to also think about the providers that are working with us. And while the incentives, of course, when you speak to PE firms or any investment firm, I've not met a person in PE yet that said, I want to have bad things happen to patients. I've not met one yet, not one. However, the incentives are slightly different. The incentives are profitability. So there's an opportunity. Maybe we need to shift the incentives better or different. But there's a focus shift that occurs. It becomes more shift on efficiency, on operational efficiency. How do we reduce the costs? How do we reduce the expenses of the practice? Because ultimately, at the end of the day, benevolence is not traded on a stock market floor. It's profitability, and that doesn't necessarily mean it's profits over patients per se, but the incentive is so strong for profitability that can shift. So one point I think to remember is how important it is to have a physician engaged in no matter what deal that happens. A physician has to be there in the business side of the entity.
For sure. I like that. Benevolence is not traded on like the stock floor. And then moving on to like the ugly aspects of private equity. So I grew up outside of Philadelphia, and like Hahnemann Hospital closed down after a private equity deal. So what are like the ugly stuff that may affect patients?
So you could see decisions that are made for profitability that may decrease the ability of access for certain patients. Hahnemann was one of the examples that you mentioned, right? There have been some studies that are oftentimes reported about nursing home patients having worse outcomes that were associated with private equity deals. But there's also some devil in the details. This was pre-COVID. During COVID, some of the same patients with nursing homes that were private equity backed actually did better. Could it be because they had more of a runway, a financial runway during a very difficult time? We don't know. I think, as I mentioned before, the ugly aspects are if profitability is your only incentive and only driver, you can have some market failures that occur, and you can have some failures where you have winners and losers, winners being profitability, patients being losers. That said, I want to reiterate, I've yet to meet someone that says, I don't care about what happens to the patients. I've yet to meet someone say, let's make things worse for patients and doctors. I've seen most people say, let's operate with the system that we have, and let's try to make improvements, and let's try to make a profitability. I have to say, I think that the profit over patients is just simply too reductive, and I don't know that necessarily boils down really what the issue is.
Yeah, so I think that the main thing, or the common thread being discussed, is like incentives at the end of the day have to align to ensure all stakeholders are benefiting, especially when profit is one of the driving incentives.
Exactly.
And then one thing I think we need more of, and you maybe touch on this quickly, it's like there's like a lack of data on outcomes in PE acquired physician groups. And I know that people throw around like, oh, everyone signs an NDA, but I think having transparency would definitely help us create a firmer debate over private equity's role in healthcare.
Agree. So transparency is going to be important. Having some regulatory guardrails are important. And, straight profiteers are not going to love the word regulatory guardrails, but in a system that is capitalistic, but we hope to have compassion infiltrate into the system, there needs to be that where we incentivize outcomes on, of course, patients as well. But here's a challenge. Most private equity deals are running between 4 and 10 years. And having a longitude review of outcomes really becomes challenging when you're looking at patient outcomes, when you're only looking at a 4 to 7 year time horizon. So data is a challenge with some of these firms. On the contrary, you also see for-profit hospitals, stock traded organizations, as well, having very similar type of incentives. And so it's at times, I think, very challenging to say what is better, what is worse, and then what are the outcomes, because there's a lot of similar incentives that are there.
No, definitely. All right, good answer. And then you touched on regulation. So that was the good. We just talked about the good, the bad, the ugly in private equity. So now I want to touch into like, what does the future look like in this space? And one of the questions that an audience member asked in yesterday's newsletter was, do we foresee any increased federal regulation or scrutiny over such private equity deals?
So scrutiny, yes. Regulation is much more slow. I will say that, so you'll probably continue to see, depending on which party is in office and in what office or what position, you'll see certain levels of scrutiny. But let's be honest. I mean, there's bipartisan support for private equity. There's bipartisan support for the stock market, which many PE firms are traded on the stock market. There is bipartisan support for profitability in healthcare. Right. So where do I see this going? There's only a couple of places you can get capital for innovation and investment. And one is the private sector and one's the public sector. And there's a lot of antibodies towards full government funding of the healthcare system. Right. So I don't think that PE is necessarily going anywhere, but there may be some regulatory guardrails that need to come up. One being from HHS looking at Department of Health and Human Services, looking at outcomes, making sure quality is maintained, but also shifting the payment system fully from a fee-for-service system to more aggressively moving into a value-based care system, which tends to incentivize outcomes. And we really haven't seen that fully yet in the United States because we're so heavily fee-for-service.
Right. And that the value-based care reimbursement and the risk-based reimbursement would certainly help to align incentives where patients need to have good outcomes in order to get the bonus reimbursement from CMS and so forth.
Exactly. So making that shift. But guess what, Jared? That takes investment, that takes IT investment, that takes some level of coordinated care or a lot of coordinated care. And that has to shift the incentive from volume to value. And you have to have a player in the game that's big enough to help fund that system. And so where do you get the capital? Stock market, private equity. There's not a lot of places to get, and government investment, of course.
Right, for sure. All right, great answers. So we have about 5 minutes left, and so I want to get questions from the audience. There are a lot, so I'm going to have to do a follow-up email with answering some of these questions. But the first one from an audience member here today was, with recent large exits and PE acquisitions, do you believe that primary care is overplayed opportunity for PE?
So let me just take the question a little bit differently, because we are seeing a growth over the last year in Medicare Advantage, which requires heavily a primary care component. Medicare Advantage is a capitated model of healthcare where dollars are paid a fixed amount per beneficiary, and then the entity has to control the care, the cost of care and the outcomes. That is growing, again, bipartisan support with some scrutiny and regulatory changes coming down the pike. But point is I see growth there. So I do think primary care has to have a focus. And if we see, or has to be a focus of PE, and if we see the trend lines from the move of in the walls of the hospital, especially where investment is happening, and also financial incentives are happening to outside of the walls of the hospital, I see that that's a growing trend in that space. I mean, just look at CVS Health, Walgreens, Amazon, Walmart, all of those big entities, again, for-profit entities, are expanding into that primary care space. And a lot of the rationale behind it is to have control of the entire patient continuum and to control costs underneath the umbrella.
Right. And to segue, so my next virtual event in a month from now will be on these big retailers like Amazon, Walgreens, all getting into the primary care space.
I knew that, Jared. That was for you. That was the layup.
Yeah, thank you. Good segue. And then the next question isn't so much of a question, but I guess I want your comments on it.
Sure.
So basically, with the whole a leveraged buyout model. The private equity acquires your group with the hope to sell within 7 years. Another firm comes in, does the same thing, all while they're trying to trim the fat of like any waste. But at some point, there's going to be nothing left to trim. So any comments on that, where it will reach a point where like nothing more can be done?
Oh, absolutely. There is a crossover point where you can cut costs so much that you end up having quality issues, where you can also improve quality or so much that it becomes so cost prohibitive that you can't do it. So I think that there is a happy medium between those two. But I think you have to get to what is cutting costs. Is this cutting bodies that are taking care of patients? Or is this leveraging technologies like AI, for example, to reduce some of the work burden, perhaps in the future, on physicians or clinicians? And that requires some level of capital improvement, capital investment. So I think that this is where there could be some regulatory pieces that are coming in to help ensure that outcomes, workforce experience while they are there, are maintained. Physician wellness is maintained as we start to move into cutting some of these cost drivers. But Jared, you and I have had these conversations. You have to also say, why are the costs dropping? You can't just blame it on private equity cutting costs. They are cutting costs in response to a decline in reimbursement.
Right.
Why is there a decline in reimbursement? Well, payers are consolidating. Payers have a very heavy hand in being able to control the reimbursement environment. Are they bad? Not necessarily. They're trying to make a profit too. That's what their shareholders want them to do.
Mm-hmm.
So this is where the systems actually have to work a little bit together to get the outcome that we want. The system that we're getting right now is the system that we've designed. If we want a different system, we have to design and regulate slightly differently. And I know that's an ugly word in the profit world, but we have to do things a little bit differently, or maybe even a lot differently, to get a different outcome.
Right. My favorite quote is, every system is perfectly designed to get the results it gets. Right. And that applies perfectly to healthcare. And then one last question. This is from a response to the newsletter yesterday, but how much effort is being made for private equity to work with physicians as partners versus we're now acquiring you and you're now like my employee?
Sure. So I think the question comes to very specific to the PE firm. Mm-hmm. Different private equity firms have different amounts of engagement with the management of the companies that they own, and then therefore by extension with different engagement with the physicians that are underpinning them. And this is from many discussions that I've had with other PE firms. Not all PE firms are alike, and not all the focus of every PE firm is exactly the same, and various firms will have different levels of engagement. What I would say, to answer that question slightly differently, I would encourage to ensure that you have the best outcome for patients, the best outcome for physicians. You must have a physician at the boardroom table being able to answer some of the questions, advising the team on some of the decisions that may be had. They should not be relegated to the children's Thanksgiving table.
Right.
They need to be there because they're such a critical component in the healthcare ecosystem. And every decision essentially that's made for the cost of care is written by a physician or provider's pen, either digitally or physically. Right. And so they need to be there as a bit of a check and balance to the business decisions within healthcare.
For sure. Great answer. All right. There's a ton of more questions that I'm just going to have to follow up with in an email. But everyone, thank you so much for your engagement. Adam, we're going to have to do this again because it was just phenomenal. You're very insightful. And for everyone else, the next Huddle Chats will be with Blake Madden, who is my colleague and founder of Hospitality, another healthcare newsletter. Great newsletter. You have to read it. It's in 1 month from now. And Adam hinted at Walgreens, Amazon, CVS, all getting into the care delivery space. So we'll be talking about this, the rise of retail health. So everyone, thank you so much for coming.
Hey, thanks for having me, Jerry. This was awesome. Really appreciate it.
You got it. So long, everyone.